We are starting. Welcome to the ninth in the case series discussion of GHU RISE clinical case series.
Thank you, Surendra. Good morning, good afternoon, everyone. Please mute your audio if you've not done so already, and as you're joining, please mute. So welcome everyone to session 9 of our COVID-19 clinical case discussion series as a joint collaboration between Johns Hopkins University, RISE, sponsored by USAID and the Johns Hopkins University. We have another fantastic session today with several experts, Dr. Yukim Nabi from Johns Hopkins University, who's a professor of medicine, Dr. Oliver Leyendecker, who will be talking to us a little bit later about diagnostic testing, and of course our Indian experts, Dr. Sanjeev Boy, Dr. Selvi, Dr. Lakshmi, Dr. Singh, and Dr. Kumar. I'm Dr. Souvik Chatterjee, an assistant professor of medicine, director of the Hopkins Bayview MICU, and soon to be program director of the Pulmonary Critical Care Fellowship. Here's our breakdown. We have a unique set of circumstances. So we do our welcome, our introduction. We then have a brief case presentation to get everybody's mind thinking about the clinical world. We then have a focused panel discussion, which will be about 15 minutes. And then we close with an evidence-based review, which will really have some take-home points for you. In addition, you'll be receiving a comprehensive document that will give you some other take-home points that you'll be able to review outside of this webinar. We do encourage questions to be asked, but please ask them in the chat. And for our experts, please feel free to answer those questions as they come up in the chat. We do like to make the session somewhat interactive. We only have 1 hour though. We do like to end on time to cover quite a bit of material in a complicated and of course ever-changing and dynamic pandemic here. So first, I want to make sure we identify our JH PIGO leaders from India, Dr. Bulbul Sood, Dr. Sumesh Kumar, and Dr. Vineet Srivastava. Without all these people, and none of this would be possible, and so it's important that we take just a minute to recognize them. From the USAID India Health Office, I would like to also recognize Sangeeta Patel, Dr. Amit Shah, Cynthia Geyer, and Vijay Paul. And Cynthia, if you are on, we would like you to please welcome everyone and say a few words.
Thank you, Dr. Chatterjee. Good evening, everyone. On behalf of the U.S. Agency for International Development, USAID, I would like to congratulate the All India Institute of Medical Sciences, New Delhi, on their efforts to mitigate the COVID-19 pandemic and setting the guidelines for the entire nation. At the outset, we at USAID would like to share our gratitude to Dr. Randeep Guleria, Director of AIMS, for spearheading the COVID-19 response. And we would also like to thank Dr. Sanjeev Boy and his team at WHO Collaborating Center for Critical Care for their excellent contribution for this capacity building intervention for healthcare providers working in COVID-19. We would like to thank Johns Hopkins University and Johns Hopkins India Institute, FIND, and AIMS New Delhi for collaborating with the USAID supported RISE program implemented by JPIGO to initiate this clinical case series that brings together clinical experts from the US and India to share their knowledge and experience on relevant topics of COVID-19 to COVID critical care providers from across the country. We're really proud to be supporting this initiative, and I'm honored to be with you this evening. These have been difficult times for our country and for India, and USAID is committed to standing with India to address COVID-19. Our collaboration builds on more than 70 years of US-India partnership and cooperation in health. To mitigate challenges posed by the COVID-19 pandemic, USAID is working closely with the Government of India, state governments, and our partners to provide life-saving care and treatment, deliver public health messages and safety precautions to local communities, strengthen case finding and surveillance, build the capacity of critical care workers, and mobilize innovative financing solutions to bolster emergency preparedness, response, and recovery. Throughout the pandemic, USAID has continued to support vital initiatives that address maternal, child, and adolescent health, TB and HIV, and strengthen the healthcare system for improved access to quality services. The unprecedented surge in cases during the second wave highlighted the need for healthcare workers and nursing staff who are well trained in critical care management and are able to treat patients who require a high level of hospital care more efficiently and effectively. And through our RISE project, USAID has been working closely with various institutions that are centers of excellence or hubs that can build critical care management capacity of several COVID care facilities, the spoke facilities that healthcare providers across these RISE intervention states, so they have the skills and information needed to treat the most critically ill COVID-19 patients. So we're really excited about this fortnightly case discussion series, and this is the 9th. And we believe these type of events go a long way in addressing the capacity building needs of many providers and also promotes knowledge sharing as the pandemic further evolves. So I'd like to welcome all the participants who are attending today's session and really share USAID's appreciation to the expert facilitators of today's session. Thank you very much. And back to you, Dr. Chatterjee.
Thank you so much. And I will say it is so rewarding to even be a part of this. This type of collaboration, I think, is going to be the future of medicine, and so it's wonderful to be a part of it. So you've heard a little bit about the leadership team, but we also want to point out a couple people that are behind the scenes. Obviously, it's one thing to be experts in something; it's another thing to sort of gather experts and get them all talking to each other. And obviously, Dr. Hensodi is a big part of that. Behind the scenes, also we have Dr. Asula and Dr. Seth, who are going to be helping to make that comprehensive document and helping to put things together for us. So that's some of who we are, but who are you and who's the audience here? So you can see we have almost 350 participants from 27 states in India, doctors, nurses, paramedics, frontline providers who have been battling COVID now for the past year and a half, almost 2 years. And so we thank you for your participation and aim to give you high quality education here. And so with that, I will turn it over to Dr. Sanjeev Boy, who will be presenting our case. Dr. Boy, I will be available to advance the slides, so you just let me know when you need to move to the next slide.
Can you hear me, Dr. Swami?
Yes.
Okay. So good morning, good evening, and I welcome to this interesting case presentation. And I also thank the John Hopkins University and this RISE program, which is really spearheading in disseminating knowledge and expertise among the physicians across the world, especially benefiting our Indian physicians. And it is very important that we learn through case learning. It has been a great achievement, and and after that, the discussion is very important, how we can actually pick up more interesting cases related to COVID-19. So today's case discussion is one of them, that it is it was during the second wave. Actually, we got this case, which we are going to discuss today, which I'm going to share with you. Very interesting that we were on the floor. It was there. Young 50-year-old. Can you advance my slide, please, Shravi? Yeah. So a 50-year-old female, we presented to the emergency department with history of chest discomfort, dizziness, and recurrent episodes of loss of consciousness. And this patient comes to the triage area, and the patient was immediately triaged because based on the symptomatology, and he had triaged to a red area. This patient did not have any previous comorbidity. May I have the next slide, please? The patient's airway was patent. She was a respiratory rate of 22 per minute. Saturation was fine. The patient's heart rate, you can see significantly low. Patient was bradycardic, and the BP was 92/64. The patient was conscious and oriented, you can see. So the main problem in this primary survey was the patient was bradycardic and had symptoms, significant symptoms of low perfusion. That patient had chest pain, dizziness, and recurrent vomiting. May I have the next slide, please? Immediately concerning vitals, then patient was triaged as priority 1, or the red, what we call in our the AIMS triage protocol. Immediately the patient was put on oxygen, IV oxygen and monitor. And you can see on the monitor, there is some concerning rhythm. May I go to the next slide, please? So if you see this ECG very carefully, there was features of complete heart block. You can see here that you can see the AV dissociation, which I have marked in blue, and the ventricular rhythms and the atrial rhythms are actually are in fixed position. So there is a complete AV dissociation, and the patient had complete heart block, and you can see a widened QRS. So this was concerning for us, and immediately the patient was managed. Next slide, please. Was managed, by simultaneously doing did a transcutaneous spacing, and the cardiologist was called. The call was given. In the meantime, the labs were sent. So the patient actually slightly stabilized by using the transcutaneous spacer, and you can see the labs. You can see the labs. The major thing is you can see the majority of them was actually normal, except even the troponins and the sequential troponins also were negative. The blood gas was okay. Next slide, please. So at this moment, we actually, this was the primary survey. We had brief history primary survey. We saw that except bradycardia, there was no other abnormality. Patient was put on transcutaneous pacing. The labs were okay, and delta troponin was no rise. You can see the ample history. There are no history of allergies, no concurrent drugs which can attribute to the bradycardia. The patient who had no comorbidities like diabetes, hypertension, or past CAD or CVA, no complication. Then in this, because the patient in the peak of second wave, we significantly asked the history of any history of symptomatology pertaining to COVID. And you see that the patient did not have any history of fever, shortness of breath, no GI symptoms, no upper respiratory catarrh. Next slide, please. So here is the problem. Here is the immediately it goes into mind that what we are dealing with, the classically, and how did we move forward. So that we're going to discuss a little bit. And at this moment, what are the diagnoses, what everybody thinks of. So then it will be interesting to little bit. So what we thought was an acute coronary event, which can lead to a complete heart block like this. And we kept other differential diagnosis that at this age group, and ACS was the topmost priority. That's why we had already activated the the cardiologist as well as the labs, and we saw this thing. The second differential we thought of before the labs actually came was maybe a myocarditis causing a complete heart block, or these are the two initial differential we thought of. And this is the case for today, and we're going to discuss and the various possibilities over it, Dr. Souvik. And then once we discuss in the due course of time, I will tell what happened, in the hospital stay and what was the final diagnosis. And then we can dissect it one by one. Over to you, Dr. Souvik. You're mute, Dr. Souvik.
Sorry, we do have one last slide. It's not my first time in Zoom. We have one last slide here. I don't know if you want to talk about the quote as related to your case.
Sorry. So I just missed that. Definitely this is the quote, what the eyes don't see, the mind doesn't know and it does not exist. So, but here I say that we're going to, we discuss the various differentials here and how we proceed. We'll come one by one after discussion.
Great. So, Dr. Sanjeev, I will start with a couple questions that I have about this case.
Sure.
The first is you mentioned that this patient didn't have any history, relevant history of cardiac disease, and you gave us quite a few normal labs. Can you walk me through a little bit about if the myocarditis was on the differential, why was the troponin not positive? And then we'll start talking a little bit more about some of the COVID diagnostics with the group in just a minute.
Sure. I said that before the labs came, before the labs actually troponin came, initially we thought about an acute coronary event or maybe a myocarditis causing a complete heart block. These are the two differential we had kept beside the metabolic parameters, metabolic component that also can lead to a complete heart block, like hyperkalemia or potassium disturbance or calcium disturbance can lead to a complete heart block. So these are the things we kept in mind before the labs came. So then when the labs came, then definitely you will rule out troponin, should have been elevated in case of myocarditis. So that you can rule it out actually, that you can rule it out that may not be myocarditis which is causing as one of the differential. That is how actually we thought of.
I gotcha. And then the other question I had is, and this is always relevant for diagnostic testing, is at the time of this case, what was the prevalence of COVID positivity in the area where this patient was from?
See, this patient actually, the COVID positivity was actually, it was here, what we have done is, so it has come around, you can say, more than 20%, positivity rate. It was, in fact, during the peak, initial peak of the second wave. I think it was somewhere in May, of this year, we got this case. So it was going up, it was not below 10%.
Got it. And then